Check, 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 check. Exactly, 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 exactly. All right, good morning. Cold Albuquerque, New Mexico. Just wanted to welcome you all to this week's live stream. Just talking about what we do here at the Man vs. Prostate Crusade. Thank you all for being defenders of the detrusor, and together we are making a difference. And just a quick reminder that the AUA is coming up in May. There's some previous slides talked about the EAU coming up in April. So please sign up and let's exchange thoughts and ideas about how to save more bladders of the now and of the future. And as always, there's the Society of Benign Prostate Disease coming up next week. Excited to be there to speak and to meet. And let's talk about how we can be better defenders of the detrusor. And so today we'll talk a little bit more about the IPSS being an invitation between the provider and the patient, as well as we'll make some quick commentary from just learning from the experts like Defender Klaus Rohrburn, and hopefully we can move from there. So let's get going. As always, a morning tea quote. Remember, every day, some ordinary person does something extraordinary. And today, it's your turn. And that's from Lou Holtz, a famous football coach. Gratitude to all of the Brigade of the Americas, from Canada to the East Coast, the West Coast of the United States. And together, we are making a huge difference. And special thanks and shout out to Defender Stephen Kaplan for at least giving the concept of man versus prostate an audience and an opportunity to share the message at last year's AUA. When we use the term urologist, I just want to be very clear. It takes a village. Together, we are a tribe. Nurses, nurse practitioners, MAs, physical therapists, administrators, C-suite executives, as well as healthcare industry representatives. And together, we save bladders. As always, thank you so much to the Italian Brigade that has really been pushing this message of bladder preservation health in Europe right now as we speak. One of their huge leaders is Dr. Defender Luca Sindolo, who's now been presenting the 5 stages of bladder health at conferences in Europe. So we're excited to see, because together on LinkedIn, we have chosen that we believe the EAU will be the first guidelines to adopt and to take that step to make it a priority to preserve bladder health. As always, thankful for the Scandinavian Brigade and the South American Brigade. And I need to get more slides up about other parts of the world, as well as down under in Asia, in India, because together we are effecting positive change. Next up, as we become more global, I think it's really important that I pronounce people's names properly. And I want to sincerely apologize because I think I've just been doing a terrible job for one of our great Scandinavian defenders, Sunny Celine. And I think I got that right. I think the C and the H are silent. Sunny, please let me know if I'm getting that wrong. Everyone else, please call me out. If I'm saying it incorrectly, your name, please let me know. I apologize up front because there's so many fantastic names out there, and names are just so important. As always, we want to honor the rising stars of the future, the defenders of the future, as they begin to understand that the prioritization of the preservation of bladder health is so critical for BPH, BPO patients. And here we celebrate a young urologist from Morocco, and I am going to have to reach out to him to figure out how to say his name properly. So that will take a little bit. I think it's Jafar Fouimtizi, and he's from Morocco. So thank you, Jafar, for being part of our tribe. So let's kind of get going. Just a quick reminder, our 3 Ps, the preservation of bladder health, putting an end to the polypharmacy epidemic, and preventing late-stage BPH, BPO. We salute once again Defender Amanda Chung, who really highlighted with her recent electron microscopy work, showing the death and destruction that happens when we allow bladders to be victimized by a tightening prostate. And we go from normal looking bladders on the top here to trabeculation, to cellules and diverticuli. And at a electron microscopic level, we see the death and destruction of the detrusor muscle being taken over by collagen, making the cells look dysmorphic and spreading them apart so they cannot be functioning properly. As always, we salute Defender Roarburn for reminding us about the window of curability, which actually was a concept introduced back in 2001 by Defender Andrea Tubero from Italy. Once again, those Italian brigades are constantly thinking in an innovative way about bladder health. And yes, the bladder is the all-important, the all-amazingly complex, one-of-a-kind organ that is simply not transplantable, that it is that amazingly complex. And we need to be intervening at the right time within the window of curability for the bladder. And as we move forward, as we understand value-based care and shared decision-making, we need to understand it's not now just between the patient and the urologist. The bladder needs to be allowed to take a seat at that table along with healthcare systems, and it needs to be allowed to voice its concerns, and we need to take that into consideration. Because right now, the Man vs. Prostate Manifesto is being worked on by all of you. Thank you all for all your feedback as we understand in the bottom right-hand corner that medications are temporizing measures, not therapeutic measures. We understand that we need to start thinking about screening asymptomatic men, potentially starting as early as 50. And we need to continue prioritizing the preservation of bladder health and break up the manifesto into two parts, the evaluation and the de-obstruction. For the evaluation, there's going to be counseling, education, triaging, risk stratifying with bladder health baselines so that we can make the best decision about surgical choices based on four things, not just prostate size and prostate shape, but more importantly, detruser function, and recognizing that it is a shared decision-making process, not just only between the provider and the patient, but also the bladder and the healthcare system. Because we are not only treating bothersome symptoms, we are treating bothersome fears. And that's right. The biggest fear that we have as providers, the healthcare system has, as well as for the patient, is late-stage BPH, BPO. And that's why I introduced the 5 stages of bladder health during the pandemic as a pathway decision-making aid. And I once again salute Defender Luca Cindolo, a leader of the Italian Brigade, for getting this concept and running with it and getting it published in the Journal of Nature, Prostate Cancer and Prostatic Diseases for everyone out there to begin to appreciate. And I really appreciate his academic insights and his wisdom. But yes, the late stages of stage 3, urge incontinence, stage 4, acute urinary retention, and stage 5, detruser underactivity. And together, we need to mount an effort to stem the tsunami of late-stage BPH, BP4 that is crashing into the shores of our countries. If we talk to Sunny, Celine, as well as the UK defenders, we know that they are showing up in the emergency rooms in retention, and we need to be able to support them together. And that's why we came up with this triaging platform that's being worked on right now. In brief, those folks who are IPS scores that are moderate to severe, plus a Qmax less than 15 and or a PVR over 100. Also, for those who have reported a history of urge incontinence or spontaneous retention, they are at risk and need a bladder health baseline that at a minimum needs to be cystoscopy. We need to trust the truth of trabeculations, as well as urodynamics, cystometrogram, as well as pressure flow studies if they're available. We need to be making sure that we provide accurate data up front so we can do a proper informed consent. And so we can help manage expectations, and we can also understand the proper timing in the window of curability for de-obstruction. And finally, here we are working on now, how do we practice the art of listening to the bladder? Well, first, it's with getting a bladder health baseline and listening to what the bladder tells us through cystoscopy and urodynamics when available. Because those who are at risk with obstruction or detruser underactivity, those individuals, the care may need to be personalized where we try and maximally de-obstruct those prostates to maximally preserve detruser function. And so with that quick break from what we've been talking about, as always, on this day in history, I like to just kind of bring up some things that have happened on February 1st. So in 1788, the steamboat was invented. In 1884, the first Oxford English Dictionary was published, and they only did entries from A to ant. And in 2003, the Space Shuttle Columbia crashed. Moving forward now, we've talked about IPSS. In our past episodes, we've recognized that IPSS does not predict the spectrum of disease. The distribution of IPSS is very similar across the whole spectrum of disease progression from unobstructed to obstructed, as shown recently by a great paper by Defender Tobias Kohler and Defender Sankar Kaushik, looking at pressure flow data. And I think that's a really important article. And we all understand that it just showed us what we all suspected, which is that men are not reliable witnesses to their own bladders. They have been providing false testimony to us. They don't know what's going on with the bladder. And the only way that we can really dig in and see what's going on is by getting data, qualitative data by cystoscopy, quantitative data by urodynamics, if available. And I recently highlighted another rising star, another defender of the future, Luca Morgantini, a resident at, I believe, in Chicago, where he really has introduced the concept that I think we can do better with the IPSS. And I just want us to recognize that just like we are human beings, more importantly, we are human becomings. We are all part of change. We are all part of evolution. And just like that, the IPSS should continue to evolve. And as we begin to try and figure out how to make the IPSS itself better, a very simple thing that we all can do is just remember to add one simple question on it. Ask about urge incontinence, stage 3 bladder health. That should be a trigger that there's something definitely wrong, regardless of what the IPSS score is, and they need a bladder health baseline with cystoscopy and urodynamics when available. And so with IPSS, I think for right now, we need to continue using it because we need something. We've built a huge foundation of research built on IPSS. And for the future moving forward, we need something that we can still relate back to all the past history of research. And so for that reason, at least keeping what we know about IPSS for right now. I think the concept of evolving it so that it can be a better match for the literacy levels of the modern man is a great idea. Here in the Americas, the literacy rate is in decline. And so we need to be able to match that to get as helpful history as we can, understanding that men are just terrible witnesses to their own bladders. And then I think finally, we need to talk about the fact that the IPSS, while it may not provide us with accurate data, it is an authentic invitation. And let's talk more about that now. When we talk about an invitation, it's inviting both the provider and the patient to engage in a shared decision-making process. Here we see it once again. All the items on and this is from the NHS in the UK. And we can divide up the IPSS into avoiding subscore and a storage subscore. And let's walk through this slide because the IPSS is an invitation. And at least how I use it, I guess, let me just show you how I kind of work through it. Here's a sample of an IPSS. This is actually a guy, like 72-year-old guy that came in with Peyronie's. A big shout out to Defender Garrett Pullman for just highlighting on LinkedIn that, yeah, it's really important to be getting IPSS scores out to guys 45 years and older as just general screening. They may come in for Peyronie's disease. They may come in for low T. They may come in for erectile dysfunction, but many of them, probably about 35% of guys over 65, will have moderate to severe lower urinary tract symptoms. And we need to capture them. And if we don't ask, we won't know. So often what I'll do with an IPSS is just express gratitude. I think that's the easiest. Hey, Mr. Smith, thanks for coming in. Man, I'm so grateful that you filled out this IPSS because I begin to worry about guys when they score 8 and above. And Mr. Smith, you scored a 17. And you know something? That's not okay. And at that point, I introduced to them the urban myth. Remember, urban myths are stories that are not true, but are often repeated and believed by many to be true. Well, with the IPSS, unfortunately, we've misnamed it. It's called the International Prostate Symptom Score, but it's not just about the prostate, and that's the urban myth. And so often I'll say, hey, Mr. Smith, just so you know, A lot of people don't realize this. It's kind of an urban myth. Everyone thinks that this sheet right here is about the prostate, but it's actually about your bladder health. Patients like that when you invite them into a secret, right? That you're sharing with them something that nobody else knows, and it actually it has to do with their personal health. They are going to really appreciate that. And the third thing on this item is it's important to establish with the guest that the bladder is so important. It's so amazingly complex that it's not even transplantable. So often in my encounters, hey, Mr. Smith, I just want to let you know that there are only two major organs that cannot be transplanted, the brain and the bladder. Yeah, that's actually right. It is so amazingly complex. It is not even transplantable. You only get one bladder in your life. So we need to work together to take care of it. And the fourth item on this slide is the cardiac analogy, just making sure that they can understand something that's more relatable, which is the heart function. And so often it'll be something like this. Hey, Mr. Smith, and just so you know, the bladder's just like the heart. The heart is a muscle that pumps blood. The bladder is a muscle that pumps urine through the prostate. And the prostate starts out about the size of a golf ball, but it is in the shape of a mini donut. And as you get older, that prostate gets bigger and that donut hole gets smaller and tighter. What this allows us to do is now engage into the 5 stages of bladder health, where it might sound something like this. Hey, Mr. Smith. And so as you get older, your bladder actually goes through 5 stages of its health. And the first stage is things slow down. That's right. So as that donut hole gets tighter and tighter, your bladder muscle is having to squeeze through that tighter hole. And as that donut hole gets smaller and tighter, things are going to slow down. And then stage 2, if you don't take care of things, your bladder now is having to work harder over 5 years, 10 years, 15 years, 20 years, and it's squeezing harder and working harder, and it actually begins to quiver and becomes overactive. That's stage 2, the overactive bladder. And as it quivers, that causes urgency, frequency, and getting up in the middle of the night. And in stage 3, just like a rebellious child, your bladder can act out without your permission. It can actually squeeze all of a sudden, causing you to leak on yourself. And in stage 4, just like the heart can have a heart attack, the bladder can all of a sudden stop working and you show up in the emergency room needing a catheter. And in stage 5, just like the heart can go into heart failure, the bladder can go into bladder failure, requiring you to have a catheter for the rest of your life. But unlike the heart, right, where when the heart goes into heart failure, you can still get a heart transplant. With the bladder, once it goes into bladder failure, there is no ability to get a bladder transplant. You're stuck with that problem for the rest of your life. And then the second item on the right here is that we need to introduce to them the concept that data drives decision making. And so it often might sound like this. Hey, Mr. Smith, so you can see my concern. Our shared goal here is not to allow you to get to stage 3, 4, and 5. And we need data. I need to have a sense of what's going on. And there's 3 main pieces of data that I need, Mr. Smith. One is prostate size, prostate shape. And the last one is your bladder health. Where are you in the 5 stages of bladder health? And with that, what we have done on this last item on the right, where I'm saying gravity of the situation is so much more than the intensity of the evaluation. What we have done is by introducing the 5 stages of bladder health, we have given them a sense of, well, this is serious stuff. I don't want to be that guy that's going to need a catheter or show up in the emergency room because I can't pee or urinary tract infections. We both now are on the same page that we do not want our patient, we do not want Mr. Smith going to the emergency room, entering stages 3, 4, and 5, urgent incontinence, acute urinary retention, and bladder failure. And that's why we need to do this evaluation, even though they may think having a cystoscopy, a camera up the penis, or bladder testing seems invasive, or transrectal ultrasound, it's worth it because the patient, Mr. Smith, does not want to enter late stage BPH, BPO. And so with that, I think what we're seeing is that the IPSS is an invitation to the patient to lower his defenses and to take off his armor of masculinity and to engage with us as a team to begin to make sure they don't enter in stage 3, 4, and 5, and that we maximize their bladder health so that they can live the best version of their lives, chemical-free and catheter-free. And for us, it is also an invitation. It is an invitation for us to be their guide on their adventure where we are hoping that they can be the hero of their own story. We need to be the Gandalf to their Frodo. We need to be their Yoda to their Luke. And with that, let's quickly listen to Klaus Rohrburn here, and just let's see if we can just build upon the concepts of this urologic giant who has helped us define the core cornerstones of our BPH BPO care pathway. And so let's quickly bring that up, and hopefully this is going to work. We'll see. Here we go.
To start your evaluation. So let's just say a man comes in and he's bothered by some of these symptoms. So my first question would be, what does he score? So let's just say he scores in the moderate range, 17 points, 18 points, or even more, 20, 22 points. So I take a look at the score and I initially determine, is this mostly storage symptoms like overactive bladder type symptomatology, frequency, urgency, and nocturia, or is it mostly voiding symptoms? That's my first glance at it. And then I ask the patient a quality of life question. I ask him, just imagine you have these symptoms and you would have to live with those symptoms and there would be nothing that could be done to make them go away. How would you feel about that? Terrible, or would you be okay with it, or how would you feel about it? This single quality of life question sort of sets the stage, because many patients, when they are retired and they score in the lower ranges, they say, I can live with it. I can make adjustment. I just don't take a long trip, or I sit at an aisle seat in a movie theater so I don't bother anybody getting up. I'll adjust to it. I adjust my lifestyle. If that's the case, oftentimes I say, maybe we don't do anything. Maybe we just monitor it and follow up.
So that's fascinating. I think that we are seeing the evolution of the BPH BPO care pathway, where I think that we can no longer, given the golden age of BPH BPO diagnostics and therapeutics, I think we can evolve the care pathway now to say, hey, these are your symptoms. I'm concerned when it's 8 and above, when you have moderate to severe symptoms. Let's layer on some data, because at the end of the day, we really don't know what's going on with your bladder and your bladder health. Let's find out. And I think very easily with screening, with maximum flow rates, with uroflowmetry, with a PVR, let's find out what's really going on and figure out who's at risk, who may need a full bladder health baseline by cystoscopy and urodynamics when available. So let's keep listening here. I think that we're seeing now the evolution away from a drug first, I'm fine first, to a data first, pro diagnostic, bladder centric approach to BPH BPO care, where we are looking for accurate data to drive appropriate decision making.
Now, other patients will say, no, this really bothers me. I work, I'm an attorney, I have meetings, I have clients, it's embarrassing, I want something done about it. So this single quality of life question is also ingrained into the assessment. And every guideline, the AUA guideline and the EAU guideline, have that single quality of life question as part of the initial assessment.
So that's interesting to me. I think that when we look at bringing the bladder to the table of shared decision making 3.0 with the patient, the provider, and the healthcare system, I think we need to recognize what we've been doing for so long is we have been men have been communication narcissists, where the patient keeps saying, "Oh, I'm fine. Yeah, I'm fine." But they're not letting the bladder speak. And the fact is they are not reliable witnesses. They cannot bear witness properly to their own bladder. So we need to let the bladder be able to give voice and speak for itself through a bladder health baseline, cystoscopy, and urodynamics when available.
And it's really a decision-making split in the algorithm, whether the patient will go for treatment or whether he will go in the direction of active surveillance or watchful waiting. And a lot of people go and just watch and monitor their symptoms because they're not bothered enough to actually have a treatment.
And that's really important. I think we cannot trust men to know if they should be bothered enough. I think there's two types of categories of bother. There's bothersome symptoms and there's bothersome fears. And like we talked about, we need to do a better job of bladder health education, bladder health counseling, to educate them the fears that we all share. Patient fears, the provider fears and the healthcare system fears is that we're allowing too many men entering late stage BPH, BPO, urgent incontinence stage 3, acute retention stage 4, bladder failure stage 5. This tsunami of late stage BPH, BPO is overwhelming us. And we need to do a better job of explaining truly that it's not just about bothersome symptoms, but about bothersome fear of late stage BPH, BPO. And so, with that, let us quickly go back to our slides. I think we're wrapping this up. Thank you guys so much. Thank you, Defender Klaus Rohrborn, for guiding us, as always, providing safeguards and providing the guardrails that help us have this dialogue around the globe to make sure that we're helping patients live the best version of their lives, chemical free and catheter free. And so, with that, let's end with just a quick wellness quote for you all. Your body holds deep wisdom. Trust in it, learn from it, nourish it, watch your life transform, and be healthy. From Bella Blue. And as always, thank you all for being defenders of the Jetruser with your cystoscopic swords and your urodynamic shield. Together, let's go save more bladders. And with that, thank you all for being here, and we'll see you guys next week. All right, take care now. Be well. Bye.